Today on Dr. Steve TV or Dr. Soloway Live, we're going to discuss osteoporosis. It's Saturday, and I was inspired today by a very sweet patient who has osteoporosis. She was a 61-year-old female who presented to the office at her first visit and did come, in fact, for an osteoporosis evaluation and treatment. Essentially, her history and physical were normal. Her DEXA scan had a femoral neck T-score of minus 3.0 with a Z-score of minus 1.7, and the numbers in the lumbar spine were approximately the same. So the first thing is to explain what is the mechanism. Why is osteoporosis occurring? How does it happen? The major mechanism really in osteoporosis, and I'm going to first tell you that I'm leaving out a lot. I'm just sort of getting to the point I want to make. You should know that the way to prevent osteoporosis is to build your bones up as strong as possible before you're 35 years old, and hopefully you'll never fall below the fracture threshold. But we're skipping ahead. We're not going to be talking about that. We're going to be talking about the typical postmenopausal female who develops osteoporosis. So what I want to explain to you is the mechanism of coupling and uncoupling of osteoblasts and osteoclasts. So osteoblasts build bone while osteoclasts remove bone. So I want you to pretend that there's a street that is paved with asphalt, and a snowplow comes by and it actually picks up a piece of the asphalt. So now you have a pothole. Now, that would be the osteoclast removing bone to create a pothole in the bone or the street in this example. What happens next is there is a subfloor laid in the pothole. That subfloor is called the osteoid seam. That seam is composed of vitamin D. So vitamin D is used for two purposes. One, to help absorb calcium, and two, to create the osteoid seam or the subfloor to the pothole created by the osteoclast. Okay, after the seam is laid, the osteoblast will refill the pothole. However, as we get older, the osteoclast, if it were having a race with the osteoblast, the osteoclast wins out. So more comes out than what goes in. This is termed uncoupling of the normal, if you want to say one-to-one interaction between the osteoblast and osteoclast. So therefore, you can see the pothole gets bigger with less bone filling in, so therefore your bones are getting thinner. Now the DEXA scan shows low bone density. It doesn't know if it is from the pothole or from the subfloor. So in fact, an abnormal DEXA scan could mean osteoporosis or osteomalacia. It cannot distinguish the two. This is important. Most people are deficient or insufficient in vitamin D, so after checking one's vitamin D level, their vitamin D must be in the normal range. Vitamin D2 is how we store our vitamin D. Vitamin D3 is our active vitamin D. That's what we use on a daily basis. For people with vitamin D deficiency, and I know I'm off topic, but this is important. If you've got deficiency and you take a lot of vitamin D and you build up your level to normal, the question I always get is, do I need to keep taking vitamin D? Well, the same question would be, I filled my car with gas, I drove a long way and I'm out of gas. Should I refill the tank with gas? The answer is of course. So if you're deficient in vitamin D because your diet or your climate or your sun exposure makes you deficient, you will become deficient again quickly. Okay, now, how do we treat the osteoporosis in the average postmenopausal female. We use drugs that are referred to as bisphosphonates. The bisphosphonates block the osteoclast in proportion, in a manner so that the osteoclast will be slowed down and the osteoblast will have a small advantage, so that the bone will thicken rather than continue to thin. Now, it doesn't make new bone, it strengthens existing bone. There are many oral bisphosphonates. There's alendronate and all of the others in that class. The other name for alendronate would be Fosamax. Whichever one you choose, they're virtually the same. There's ibandronate, which is Boniva, and there's Actonel. The advantage of the drugs is that they work. The disadvantage of those drugs is they're very difficult to tolerate or take. They need to be taken first thing in the morning with a glass of water, standing preferably for up to 1 hour, no brushing teeth, no drinking tea. This is because these pills bind onto anything. Once bound, they are rendered ineffective. So it is very important to utilize injectable vitamin D medication, whether it's subcutaneous or IV. It's administered less, and you're guaranteeing compliance. So there is a once-a-year drug called Reclast, which is an intravenous bisphosphonate. So like the other bisphosphonates, the only difference is that it is given IV, and it doesn't matter what you eat or if you stand up. So the main side effect of all bisphosphonates is that they bind to the bone itself. And if you take them for too long and they're on the bone too long, they can lead to unusual fractures. So they are time limited. Now there's a drug called Prolia or Desuminab, which works similar, although it doesn't bind to bone. It blocks an enzyme called rank ligand, and by blocking rank ligand, it does not bind to bone. However, you need rank ligand to activate the osteoclast, so you're essentially doing the same thing. The advantage with Prolia is the Prolia does not have to be stopped, and in fact, if it is stopped, there's a rapid loss of bone. All the drugs have side effects. I can't list them all, but no drug is without side effect. Everything is about a risk-benefit ratio. I should mention that there is teriparatide and another drug, which I can't think of the name. These are parathyroid hormone analogs, and they are actually osteoblast stimulators. So these drugs are unique because they create new bone, and often those drugs are reserved for people with fractures. Now, fractures can come in many types. Osteoporotic fracture would be, by definition, falling from your feet, not from a higher height, and breaking, in particular, a vertebrae, a rib, the wrist. I'm sure I'm leaving something out, and I apologize. But if you have an osteoporotic fracture, you should be treated for osteoporosis. You should maintain good calcium and vitamin D. And if you're over 65, you should be on calcium citrate or citrate rather than calcium carbonate. Your stomach absorbs it better. And I hope you have a nice weekend. And if I didn't stimulate your brain about osteoporosis, I don't know what else to do. But I will tell you that if you're a woman past menopause or a man past 65, you are at risk. If you're taking prednisone for more than 3 months, or if you're taking an aromatase inhibitor for breast cancer, or if you're on a chronic use of a proton pump inhibitor for acid reflux. These are all risk factors. Smoking and alcohol are risk factors. If you want to be tested, you can call the office. If you haven't been checked, we will check you. Have a great day and enjoy your weekend. Thank you.